Hello, this is European Society of Digestive Oncology Learning Bytes series. My name is Piotr Wysocki and I would like to present you the topic of anemia in cancer patients. Anemia is a disorder defined as a reduction in hemoglobin concentration in blood. Definitions differ. National Cancer Institute recognizes anemia when hemoglobin concentration is below 12 grams per deciliter for women and below 14 for men. National Comprehensive Cancer Network uses a more conservative definition with a cutoff value of 11 grams per deciliter, or defines anemia as a reduction in hemoglobin concentration equal to or larger than 2 grams per deciliter from the patient's baseline value. Anemia is prevalent among cancer patients. It is generally estimated that over half of all cancer patients have anemia at the time of diagnosis. This number is even higher in patients on active treatment. Typical signs and symptoms of anemia are skin pallor, dyspnea, heart palpitations, systolic murmurs, and fatigue. Anemia in cancer patients is associated with reduced quality of life, increased morbidity, mortality, and worse response to therapy. CTCAE grading system classifies anemia as Grade 1 when hemoglobin concentration is below normal but above 10 grams per deciliter. Grade 2 when hemoglobin concentration is between 8 and 10 grams per deciliter. Grade 3 when hemoglobin concentration is below 8 grams per deciliter. Grade 4 when anemia is life-threatening or requires immediate intervention. Grade 5 is death. Causes of anemia in cancer patients can be divided into three categories. First, causes directly related to cancer. A typical scenario is bleeding from tumor, intraluminal or internal. Other cases may be related to bone marrow replacement by cancer infiltration or hemophagocytosis in some hematological malignancies. Secondly, the effects related to the cancer indirectly. For example, malignancies often lead to the production of pro-inflammatory cytokines and upregulation of hepcidin, the main regulator of iron uptake and release. This consequently leads to impaired iron utilization and insufficient erythropoiesis, manifesting clinically as a functional iron deficiency. Other causes are microangiopathies, poor nutrition, or autoimmune hemolytic anemia resulting from presence of autoantibodies. Thirdly, anemia can be related to therapy. Both chemotherapy and radiotherapy leads to the bone marrow suppression. Some surgeries, for example gastric resections, can also lead to the malabsorption of iron and vitamin B12. There are three main treatment options in anemia. First is administration of iron. In cancer patients, iron should be used intravenously, as oral preparations are largely ineffective and are not better than placebos in several studies. This is primarily related to impaired iron absorption in cancer patients, and oral iron might be considered only exceptionally. Use of intravenous iron permits to rapidly correct both absolute and functional iron deficiency, enhance response to erythropoiesis-stimulating agents, and reduce the need of red blood cell transfusions. Intravenous iron preparations are associated with a modest risk of hypersensitivity reactions. The second option are erythropoiesis-stimulating agents, or ESA. Use of ESAs leads to the reduction in the number of red blood cell transfusions and improvement in anemia-associated symptoms. ESAs are associated with some risks. First, increased incidence of venous thromboembolic events, approximately 1.5-fold higher risk. Some studies linked ESA use in cancer patients to the elevated risk of mortality and tumor progression. However, it is very important to note that this effect has only been reported when ESA were used outside the label guidance, for example in patients not receiving therapy, or when target hemoglobin level exceeded 12 grams per deciliter. There is no single evidence indicated this effect when ESAs were used within the label guidance. Other drawbacks of ESA are insufficient response or declining response over time in some patients, and very rare cases of pure red cell anemia. The third options are red blood cell transfusions. They permit a rapid correction of laboratory abnormalities and symptomatic alleviation. However, transfusions should be used conservatively. They are associated with risk of post-transfusion adverse reactions, pathogen transmission, thrombotic events, and inflammatory response. Blood transfusions have been also associated with increased risk of mortality, morbidity, and cancer progression in some studies. Before starting anemia treatment, it is important to evaluate the iron status. Iron deficiency in cancer patients may be either absolute or more commonly functional. Iron deficiency shall be recognized when transferrin saturation level is below 20%. Absolute and functional iron deficiencies are primarily distinguished using the ferritin concentration level. Absolute deficiency when below 100 nanograms per milliliter, or functional deficiency when 100 or above. Please note that this ferritin cutoff value differs from the value used in the general non-cancer populations. The European Society of Medical Oncology guidelines are shown here. Anemia treatment shall be initialized when hemoglobin level is below 11 grams per deciliter. In grade 1 cases, hemoglobin between 10 and 11, iron, folate, and vitamin B12 levels should be inspected and supplemented as required. As mentioned before, intravenous iron preparations are recommended. In case of hemoglobin level below 10 grams per deciliter, iron, folate, and vitamin B12 levels should be also inspected and supplemented as required. Additionally, ESA administration shall be considered in patients receiving chemotherapy or radiochemotherapy. Intravenous iron can be administered before ESA in the case of absolute iron deficiency or simultaneously with ESA in functional iron deficiency. Red blood cell transfusions should be only considered when hemoglobin level is below 7 or 8 grams per deciliter, or in case of severe symptoms when rapid hemoglobin increase is required. Hemoglobin and iron status should be monitored during treatment. Important points to remember: red blood cell transfusions should be only used in a restrictive fashion. Intravenous iron is recommended. Typically, a single dose of 1000 mg is given. Alternatively, multiple doses may be used. Administration of intravenous iron is discouraged in patients with active infections. They should not be used on the same day as administration of cardiotoxic chemotherapies. ESAs are only used in cancer patients receiving chemotherapy or chemoradiotherapy. When ESAs are used, the target hemoglobin is between 10 and 12 grams per deciliter. Hemoglobin concentrations above 12 grams per deciliter should be avoided. In the case of insufficient response to ESA, dose escalations and changes between different products are not recommended. Epoetin alpha, beta, theta, and zeta are usually given as a single weekly subcutaneous dose. Darbepoetin alpha may be administered either weekly or once every 3 weeks. This was ESDO Learning by Series presentation on anemia in cancer patients. Thank you for your attention.